Thank you for the invitation to talk about our work today. I'll be discussing the neonatal management of posterior urethral valves at the Hospital for Sick Children in Toronto. When we think about the overall goals of PUV management, the primary goal is the preservation of renal function. We also aim to delay or prevent adverse outcomes. We want these children to achieve social continence, and we want to ensure as few anesthetic and intervention events as possible, particularly in the newborn and infancy period. The historical management of this population at SickKids is as follows. PUV patients were managed by each surgeon, and the person on call when a patient arrived was the primary provider for that child. This meant that there was varied initial management and follow-up schedules, as well as a variety of methods for bladder drainage and the duration that they were left in place. Almost all of these patients were managed with a valve ablation, and many had their care transferred to the nephrology team for ongoing management shortly after that. The tolerance of postoperative hydronephrosis was also extremely varied by provider, as well as a tendency to assume that school-age incontinence was related to BVD and not to valve bladder dysfunction. We recently reviewed our experience with PUV to compare outcomes between pre- and postnatal presentation. After excluding patients whose pre- and postnatal status was unknown, patients with incomplete follow-up, and those not managed by us from the beginning, we were left with 152 patients. Only 39% of them had a prenatal diagnosis. Most were managed by valve ablation. A quarter of them were started on CIC, and the follow-up time is about 6.5 years. And so when we compared these cohorts, we noted no significant differences in the proportion of patients in each group who met any of these outcomes, such as CKD progression and the need for renal replacement therapy. However, when we looked at the time to these outcomes between pre- and postnatal presentation, we found that patients who presented prenatally reached most of these outcomes significantly earlier than the postnatal group. Granted, this may be due to these patients being more severe to start with, which is why they are detected earlier. However, these data made us think. Can we do better than this? In partnership with our colleagues at the High Risk Fetal Center here in Toronto, we used this data as an opportunity to see if we could improve our prenatal detection rate. We conducted a systematic review in Bayesian meta-analysis to determine the predictive accuracy of specific prenatal ultrasound features for predicting a lower urinary tract obstruction. It is recently published in the journal Prenatal Diagnosis, and we noted that the sensitivity and specificity for most features was scattered all over the place. After calculating diagnostic odds ratios for each, we found that several features are predictive of ludo on their own. Interestingly, keyhole sign, which we are taught is a classic finding in ludo, performed poorly, and megacystis was actually the strongest predictor. What we learned from this paper is that most infants will not have every classic ludo finding, and if the provider relies on this, there is a chance that many will be missed. Instead, when reviewing fetal imaging, if these features are present, either together or even in isolation, one must consider the possibility of ludo and encourage closer follow-up and monitoring. Due to the varied management described earlier, we also hypothesized that by standardizing the care of these patients, we could improve these outcomes as well. We started by creating a dedicated clinic for patients with lower urinary tract obstruction, comprised primarily of boys with PUV. We run this clinic once per month, and it is staffed by our nurse practitioners, medical urologists, clinic nurse, and flow coordinator. All patients have shared care with nephrology, with social work available as needed. We've developed standardized management plans and follow-up schedules, which is outlined in a clinical pathway. We developed a pathway after reviewing our historical practice and identified the high degree of variability in management style and associated outcomes. This was reviewed by the providers in our division who manage these patients. In this talk, I will focus on the initial surgical management tool and early infant management, and I will also use the pathway for those who were prenatally detected as opposed to those who presented postnatally. So when we know these infants are coming, we advise birth at a high-risk center, and in our case, this is directly across the street from SickKids. If possible, an ultrasound should be done. However, this should not delay treatment. The next step is bladder decompression and initiation of antibiotic prophylaxis. If the infant is born at the high-risk center, this is done by our team shortly after birth. And so decompressing the bladder seems like a relatively simple task, and there are several well-known options for doing this. Foley catheters are a common method, and as we know, they are readily available, and inserting one is considered a basic skill. One drawback, though, is the tendency to inflate the balloon in the posterior urethra, as this is the point when urine is obtained when you insert it. Another drawback of Foley catheters, as described in these case reports and demonstrated in these photos from our patients, is that newborn PUV bladders are typically small, thick-walled, and non-compliant. So when a balloon is inflated and the bladder collapses around it, the UVJs become obstructed, resulting in worsening hydroureteronephrosis, increasing creatinine, and AKI. Feeding tubes are another common method for bladder drainage. While they offer an advantage of being readily available, smaller caliber, and flexible, they have their own drawbacks. They are difficult to secure, which makes them precarious, but they are also at a risk of knotting in the bladder, and there are several case reports that describe this. This video clip is of a patient of ours from last year who had a feeding tube inserted on day of life 1. On day of life 3, there was a sudden decrease in urine output, and with POCUS, we were able to see an empty bladder and a catheter knot preventing the removal of the tube. This patient was ultimately taken to the OR and managed with a vesicostomy, through which the feeding tube was removed and is shown in these photos. An alternative is how we do it. Since 2015, the majority of PUV patients were managed upfront with the insertion of a double J stent at the bedside with ultrasound guidance. This is a short video clip demonstrating the steps. An open-ended catheter is cut to a short length and a glide wire is inserted. This is introduced into the urethra. And then the glide wire is fed into the bladder as seen in this ultrasound image. The open-ended catheter is then removed and replaced with a stent, which is then inserted into the bladder, again, as seen with the ultrasound. Once the placement is confirmed, the wire is removed and the stent is coiled inside and outside. I will add a disclaimer here. This video may make this process look easier than it actually is, as it was done under anesthesia in the OR. It is slightly more challenging at the bedside with a baby who is not anesthetized in the NICU, and even more challenging to do in clinic. We've quickly learned that the circumstraint can be multi-purpose. Stenting seems to be more difficult, takes more expertise, and takes more equipment. So why do we do it? We have found that it offers better drainage, that there are less complications, and babies seem to tolerate it very well. We leave the stents in place until the child is stable enough for VCUG and OR, which is typically around 7 days. So now that the bladder is decompressed, baby is on autopilot until it's safe to proceed. This might be a couple of days or a couple of weeks depending on the stability of the baby, as some may have respiratory compromise secondary to pulmonary hypoplasia. We are also sharing care with the pediatric nephrology team to help us manage for post-obstructive diuresis should that happen. We do the VCUG when it's safe and confirm the diagnosis. So now what? We do another ultrasound to determine if the hydronephrosis and creatinine is improving with bladder drainage. These are images from a prenatally detected PUV patient. On the left is sagittal left and right kidneys on day of life 0, immediately before a stent was inserted. On the right is an ultrasound repeated on day of life 4, showing improvement in the degree of hydronephrosis. This graph is showing the creatinine trend, which is the purple line, and it demonstrates that while not too high to begin with, after stenting, there was a decline in creatinine. So for this patient, the answer is yes. The hydronephrosis and the creatinine did improve with bladder decompression. Next, we ask, is the child big enough for instrumentation? If yes, we proceed with a valve ablation. If no, then we offer a vesicostomy. So for this case, we ablated his valves on day of life 5, and his creatinine continued to trend down. His post-ablation VCUG demonstrated no residual valves. So going back to this slide, what if at that repeat ultrasound, the hydronephrosis and creatinine did not improve with bladder drainage? This is a prenatally detected PUV, and on the top reflects an ultrasound on day of life 0 immediately before stenting. The bottom is a repeat ultrasound on day of life 3. The hydronephrosis is the same. There is now debris in the collecting system, and the bladder is collapsed with a stent in place, and the distal ureters are dilated. This infant had developed hypothermia and was found to be septic. His creatinine continued to climb after stenting. So for this baby, the answer is no. And in our practice, when this is the case, we opt for ureterostomies. They may be unilateral or bilateral, depending on the severity of hydronephrosis and the presence of reflux. This patient had bilateral ureterostomy creation on day of life 4, and as you can see, the creatinine immediately started to decline after that. An often mentioned drawback of diversion surgeries is the belief that they may defunctionalize the bladder later on. I mentioned in our pathway that if too small for a cystoscopy and valve ablation, we opt for a vesicostomy. This patient had a valve ablation at 3 months of age after presenting with sepsis. He went on to have worsening hydronephrosis and creatinine and was managed with a vesicostomy at 6 months of age. He had a vesicostomy closure at 3.5 years of age, and when he had a VCUG at age 8, his bladder capacity was 260 cc's. Loop ureterostomies are done when the hydronephrosis and creatinine do not improve with drainage, and they may be unilateral or bilateral depending on reflux status. In this example, the initial VCUG on day of life 3 showed a very small trabeculated bladder. He was managed with bilateral ureterostomies on day of life 8. He underwent ureterostomy closure and valve ablation at 17 months of age. When he had video urodynamics at age 4, his bladder capacity was found to be 250 milliliters. So now I'll touch briefly on the infant management pathway to highlight the early management after the initial surgeries. The whole pathway is broken down by initial surgery type. In an ideal world, the valves are ablated, an ultrasound is done before discharge, and then again about 3 to 4 weeks later. The hydronephrosis is improved or minimal, so follow-up takes place in 3 months. Things continue to look good, and ultrasounds and labs can be done every 3 to 6 months, with video urodynamics obtained around toilet training age or age 2. However, things may not go as planned. In our pathway, if the hydronephrosis is persistent or increasing, or the creatinine is rising or remaining elevated, we do a repeat VCUG to look for residual valves. If we find them, the child has a cystoscopy and ablation of residual valves with an ultrasound 3 to 6 weeks later. This ultrasound can be done a few times before proceeding down the pathway. If everything has improved, we move back to the monitoring pathway in the previous slide. If it is not improved, though, we place an indwelling catheter or stent for 7 to 10 days and repeat an ultrasound and labs. If better with bladder drainage, we offer a vesicostomy. If not, we offer ureterostomies. What about if when we repeat the VCUG, there are no residual valves? In this case, a repeat ultrasound can be completed in 6 to 8 weeks, and again if preferred. However, if the ultrasound and labs are not improving, medication can be considered. If there is reflux and we feel the cause is an emptying issue, we start an alpha blocker, usually tamsulosin. And if we feel that this is caused by a thick bladder causing UVJ obstructions, we consider an anticholinergic. And there are times when kids need combinations of these medications. I wanted to highlight this section of the pathway to point out that when we were trying to identify the cause of persistent hydro or rising creatinine, attempting to see if things improve with a catheter and or medications can all be done at the same time. Our reason for jumping to a diversion if things do not improve with medications or catheters and not starting CIC right away is because these are infants in diapers which cover the stomas. And we feel that once a patient is diverted, they are usually on autopilot for a couple of years during which we can relax the follow-up schedule a bit, stop some of the medications, and most importantly, preserve the renal function. This is during the first 2 years of life, which we know to be a crucial time for kids. CIC may be inevitable down the road. However, in the infant period, it may be seen as a burden to families, is very costly, and we encounter potential issues with noncompliance. Now moving on to the vesicostomy pathway. In the event of worsening ultrasound and labs, oxybutynin can be offered in an attempt to soften up the bladder. However, if the hydronephrosis and creatinine remain persistently elevated, a higher diversion will be offered. And finally, when we look at the urerostomy pathway, most of these babies do well on this follow-up schedule, and we close all diversions around the age of 24 months, followed by video urodynamics after that. Parents are aware that once they are closed, the follow-up may become more frequent again, and the need for medications in CIC may need to be discussed depending on the bladder dynamics. To conclude, when we reviewed our historical data and outcomes for PUV patients, we realized that there is room for improvement, both pre- and postnatally. By lowering the threshold for considering a luteal diagnosis based on some of the ultrasound findings and not relying on all of the features we have been taught to look for to be present, we may improve the prenatal detection rate. Postnatally, implementing a standardized pathway in a dedicated clinic will streamline care, and we feel that aggressive early management, close follow-up, and low tolerance for hydronephrosis and elevated creatinine in the infant period may improve the long-term outcomes. However, only time will tell if early detection in these interventions will change the natural history of PUV. Thank you so much for listening to our talk, and we welcome any questions to the email addresses on the slide.